To the Ethics Grand Rounds from the University of Colorado Anschutz Medical Campus. Today, we are going to hear from Drs. Thant and Murray about psychiatric disorders and capacity evaluations, ethical principles, and approaches. My name is Gianna Morales. I'll be moderating this session today. If you have any questions, you can throw them in the chat, and we should have some time at the end to discuss. I'll be able to read those after the talk for Drs. Thant and Murray to discuss. This presentation is also going to be recorded and will be available through the Center for Bioethics and Humanities website here at Anschutz Medical Campus. That link will be posted, or you can look for it in the website archives. Before I introduce our speakers, I do want to mention that our next Ethics Grand Rounds will be on April 11th at noon. Dr. Channing Tate will be addressing disparities in access to hospice care. Please remain muted throughout this talk. And now it's my honor to introduce our speakers. First, we'll have Dr. Thant, who is a faculty psychiatrist at the University of Colorado Department of Psychiatry. She is the director of the UC Health Psychiatry Service, the Psychiatric Consultation for the Medically Complex Clinic, and the Assistant Chief of Service for the CU Medicine Psychiatry Community Practices. She graduated with a Bachelor of Arts degree in Plan 2 honors from the University of Texas at Austin, attended medical school at the University of Texas Medical School in Houston, and completed her general adult psychiatry residency and CL fellowship at the University of Colorado. Her academic interests include marijuana and its impact on psychiatric practice, cannabis in medical education, and comprehensive psychiatric care for medically and neurologically complex patients. We will also have Dr. Murray presenting today. She is an assistant professor at the University of Colorado Psychiatry Department. She attended Emory University for medical school and completed her adult psychiatry residency and consultation liaison fellowship training at the University of Colorado. She currently works as faculty on the UCH Consultation Liaison Psychiatry Service and within the University of Colorado School of Medicine. Thank you both, and we're excited for your presentation today.
Thanks for having us. I know it's a lot of words in those bios, so I apologize. I'll go ahead and share my screen. And so there we go. So like we mentioned, the thing we're going to talk about today is how do psychiatric disorders and capacity evaluation sort of go together. This is something that I think a lot of people have experienced, and it's super complicated. So we are hoping to be able to have a lot of discussion and time for questions at the end. We're going to cover a couple of different things today. We're going to try to make sure that you all feel comfortable describing how mental health conditions can impact medical decision-making capacity. Think about like the main ethical principles involved in the assessment and management of these capacity evaluations, and then review some approaches and strategies for how to kind of look into this, how to restore capacity, and just in general, how to approach these cases. I think some people in the audience are going to be pretty familiar with this, but some of you may not be. So I'm going to do some foundational slides first. And so a few starting definitions. One is the difference between capacity and competency, because being on the consult service here at the U, we get asked about this a lot, and we have a lot of teams asking for us to come assess competency. So what the differentiation is that for capacity, it's really just the ability to accept or refuse treatment recommendations and to make that decision. And it's ultimately decided by a clinician upon specific elements of a kind of clinical interview, evaluation, or mental status exam. This is different from competency, which is really a legal term and is determined in a court of law. And so judges often rely on clinician recommendations and assessments, but otherwise we go through the courts for this. And really, generally, the law presumes competence until proven otherwise. That's sort of where you're coming from. And when it comes to medical decision-making capacity, there's a few basic tenets that we're going to cover. Again, it's really the capacity to make a choice freely in the absence of coercion. And this can be a decision to either accept or refuse treatment. And it's supposed to represent, or does represent, the patient's ability to make decisions in line with their personal situations, values, and history. So it does not need to be a decision that we as the clinicians agree with. It just has to kind of fit and follow a couple requirements that I'll review in a different slide. And so when we say that someone lacks capacity to make medical decisions, we're saying that they have functional deficits that are significant enough that we feel like as their medical team, they cannot currently meet the demands of this medical decision-making situation, and they cannot really make decisions or appreciate the consequences related to their decision. So when do we do this, right? Because I think that's a big thing that comes up. And technically, whether you realize it or not, you're doing this at every patient encounter, or you at least implicitly making a determination about this at every encounter. And so it's indirectly assessed as part of the informed consent process, right? Because if you think about an easy example is consenting someone for surgery, right? You're supposed to review the risks and benefits, and they're supposed to say that they understand this and it's been discussed with them. And so if you sign it and they sign it, you're saying they have the capacity to consent to surgery. Now, there are times where we should be more directly assessing this. This might be when there's a change in mental status, right? All of a sudden, a patient on your service appears confused or forgetful, or has a change in behavior or personality. Another time, maybe if a patient's declining or refusing treatment recommendations, including requesting AMA discharges. Another time would be if it's a particularly risky intervention, you may want to be more, intentional about this evaluation, or if they have a risk factor for impaired decision-making. And on a later slide, I'll talk a bit more about specifically psychiatric risk factors. And in terms of timing, it'd be really great if we could always just decide this the minute someone comes into our care, but it can't always be done. So sometimes we receive requests for, they've left AMA in the past against medical advice, and we'd like you to come assess capacity now so we can just know. And the reason that is, which I go to more in depth, is that it depends on the clinical situation at this time, their clinical status at this time, and that might be different to prior discharges. And who? Because this is the other source of contention. Frequently, there's a lot of confusion and discomfort over who's going to do this evaluation. And so really by kind of clinical guidelines, it's best done by the primary treating clinician, regardless of specialty, and does not need to be a psychiatrist or psychologist. So basic tenets, again, if you're someone who's sort of newer to this or hasn't had a chance to get to learn about this, this is from a paper from Applebaum. Different specialties have papers they like to pull from. This is the one that psychiatrists are always going to pull from when you consult us. So they're based on this paper, there are really 4 main areas or criteria when it comes to medical decision-making capacity, and that's on the left. So the first one is communicating a choice. Really, the idea is that a patient should be able to clearly indicate a preferred treatment option, and it should be pretty consistent. And so frequent reversals of choice, even if the clinical situation has not changed, should raise concerns and maybe trigger capacity evaluation. The next one is understanding the relevant information. So the patient needs to be able to understand, they don't have all the same understanding that you do as a clinician, right? But they have to be able to understand relevant components of it enough to be able to make an informed decision. And so they need to understand the condition they have, what is the nature and purpose of the proposed treatment, what are the possible benefits, as well as the possible risks, and what are other options, if not this option that you're recommending. That feeds into the third criteria, which is the ability to appreciate the situation and its consequences. So, right, not only should they be able to kind of say to you the things you said to them about their care, but they have to be able to appreciate how these things apply to them. So if you have a patient who says, yeah, I can repeat back everything you said, but I don't believe I have the disease you're talking about, and I don't believe in the treatment you're providing for these reasons that maybe don't make sense, that might be a time, again, where you're worried about their capacity. And then the final major criteria is reason about having the ability to reason about treatment options. So again, this is more focused on the process, the thought process behind how they reach their decision, as opposed to the final decision. Because like I said, they don't have to agree with us and we don't have to agree with them, and they may sell capacity. But if the process and the way they apply information doesn't really make sense, this may be another time. So you can see there's a lot of subjectiveness to this. This chart's nice because it talks about the kind of clinician's approach to this and questions you may use specifically to assess each of these criteria. So there are lots of things that can affect medical decision-making capacity. Today, we're going to focus on psychiatric and psychological factors, but really there's a lot of different medical conditions, neurological conditions, acute delirium, things like that, that can prevent someone from having capacity. But on the more mental health side, the ones on the left, these are psychological factors or cognitive biases. You could have these things without having a mental illness, all right? So any one of us can have some of these things, and these are a lot harder to suss out. So it's about your approach to problem solving, downplaying of risk, maybe being overly optimistic about how you frame your current clinical status, and sort of blindness to the effect of the decision on yourself or others. Then there's things that we get asked about a lot, acute psychiatric symptoms and disorders. So that can be things like severe eating disorders, decompensated or acute psychosis or mania, depression, suicidality, intellectual disability, and then dementias, which I include here, but really blur the line between medical, neurological, and psychiatric conditions, right? Not purely a psychiatric condition. And so today, of course, we have limited time. We're going to try to hit on these topics in red, and hopefully feel like you all have more of a sense of how to approach these and think about them. And so maybe unsurprisingly, you're going to see there's a lot of ethical principles at play here, right? That's why we're all here to talk about this. And then really, in these situations, there's a tension between autonomy, right? The patient's ability and right to make decisions for themselves, beneficence, us trying to do good things for them as their healers and medical team, non-maleficence, again, trying not to cause harm or do harm to our patients, and then justice. And so looking at that and looking at my slide from before with all the different tenets of capacity, you might be feeling like this, right? Like this is not a comfortable thing to have to do, to have to decide if a patient or a person can make decisions for themselves. And that's why there's all this finger pointing that I pointed out earlier. So we'll start with a case. Now, I took this case, changed some identifying factors, but this was a case that went on for months in the hospital, and I condensed it to one slide, all right? So we're gonna focus on really just pertinent points. So we're going to start, I'm already giving you kind of the headline. It's a bipolar disorder with concurrent dementia, right? This is something that comes into the hospital all the time. So we have an 80-year-old male gentleman, history of bipolar disorder, who got brought into the hospital on a mental health hold, actually, for grave disability, because his primary care office got worried about his ability to care for himself, and they called a wellness check. And so a crisis team went out, the police went out, and they found unsafe living conditions, rotting food, feces everywhere, failure to thrive, and a very concerning leg wound. So the patient got brought into the ER kind of against their will in a mental health hold. And in the ER was noted to be kind of delusional and grandiose, making these grand statements about who they know, who they are, and kind of what they're able to do. And they were noted to be disheveled and to have multiple physical exam and lab findings that were concerning. Psychiatry got involved and reviewed that there was a history of a bipolar diagnosis versus schizoaffective, but also significant concern for cognitive impairment. This patient, people have been worried before, and they've been doing cognitive screeners and finding low scores, like what I mentioned here, 18 out of 30 or 11 out of 22, depending which version they were doing. But the patient declined psychiatric treatment while they were in the hospital. To make matters worse, throughout their medical admission, the patient would intermittently get agitated, would frequently request discharge or try to elope, and required, medication management to manage this. We went back and forth, and there was discussion about Jerry psych admission given the patient's age, but because of their wound care needs and their cognitive deficits, really they weren't able to be transferred to any psychiatric unit. Was deemed by the medical service to lack capacity to leave AMA, basically because they realized in ongoing conversations with the patient that they couldn't recall prior treatment discussions, even from earlier that day. They couldn't really discuss treatment options, and they really couldn't discuss what would happen if they left the hospital against medical advice. And so due to the inability to identify a proxy decision maker, there was no one in this patient's life. Ethics was consulted, the physician proxy process was started, and this kind of went on for months and months as the patient was declining both psychiatric and medical interventions. All right, so this is a type of case. Many of you have had cases like this. So there are many questions and concerns raised in this case, but I'm going to focus on three. All right. First one being, what is the role of involuntary psych holds in these kind of patients that have concurrent medical and psychiatric issues? What is the role of a proxy decision maker, MD, POA, or guardian in psychiatric treatment? And what is really the difference in the capacity to consent versus refuse? So these were all questions raised in the kind of inspirational case, in the original case, when we were meeting in multidisciplinary huddles. So first, the role of involuntary psych holds. First, you have to know what those are. So I'm going to focus on Colorado mental health law. And many of you might be familiar with the idea of a 72-hour mental health hold. This is sort of an emergency hold that can be placed by a variety of people, law enforcement, many healthcare professionals. It's not specific to mental health care conditions. And it lasts for 72 hours and allows someone to be brought in and evaluated for mental health conditions. There are then a variety of legal statuses that you go through the courts for that are longer. You have to go to court and testify, the patient's there. And these are things called short-term certifications, extended certs, long-term certs, so forth. I won't go into detail, but these start to increase the amount of time someone can be held for up to 90 plus days. That's why we have to go through courts. Then those are just the legal statuses to keep someone somewhere or to make someone show up for treatment. It doesn't actually allow you to force medication. So then along with that, there are other processes. There's emergency medications, which are really a day-by-day process with a time limitation. And then there's involuntary medication or IMEDs, for which, again, we go to the courts and kind of justify to a judge why we should be able to do this. So it's completely separate from the medical decision-making process or proxy, because it's really all centered around mental health care, which has been carved out from the rest of medical care. And so these statuses do not inherently grant the ability to involuntarily treat medical conditions. So let's say I see a patient on your service, I put them on a hold for whatever reason. That does not mean you get to force medical treatment. It only applies to their psychiatric care and their ability to leave from a psychiatric care. And then these statuses should really be used for primary acute psychiatric disorders and the treatment of those disorders, right? So if someone, let's say they are suicidal or making suicidal statements in the hospital, but they're actually there for like urgent or emergent care of a cardiac condition, we wouldn't use the hold to keep them for the medical care. We would use the hold once they're really kind of medically cleared or to start the process of involuntary psych treatment. And so really our statuses go through the mental health courts. So then what is the role of a proxy decision maker, guardian, MDPOA in psych care? It's pretty limited is the short answer. Involuntary psych treatment can only be done in Colorado through mental health courts, statutes, processes. So that means that if you have an MDPOA or you have assigned a proxy decision maker for medical decisions, or they have a guardian, that person cannot consent to involuntary psychiatric treatment in the state of Colorado. So they cannot say a person needs to go to inpatient psych. They cannot consent to involuntary psych meds. A caveat is they can consent to the use of psychiatric medications to treat medical conditions. So we have someone who's hyperactive delirium and is very violent and agitated, or they're, they have dementia and they're getting agitated, trying to leave. The proxy decision maker can consent to the use of Haldol, for example, to manage that medical condition. So there is a distinction there. And then in this last question is really like, what is the capacity to consent versus refuse, right? Because a lot of times it's hard for us to kind of tease those apart. And it might be surprising to hear that a patient can have capacity to make some decisions, but not all. So really you would be deciding this on a case-by-case and a situation-by-situation basis. And you really, if you're doing this evaluation, you need to be targeting specific capacity questions. It is not a blanket ability to make medical decisions. If you're going down that path, you're probably thinking about something like guardianship. The other thing is sliding scale. So going back to the idea of balancing autonomy and non-maleficence and beneficence, the higher the risk of refusal or the medical intervention, the better the capacity needs to be to consent or refuse. So maybe routine blood draws or routine vital checks in the hospital, even if a patient doesn't really know why we're doing them, we might allow them to decide to refuse that, but we may not allow them to refuse or make a decision around urgent or emergent cardiac surgery. All right, I know I'm giving a very broad overview of this. So back to our case. What is actually the impact of psychotic disorders and mania on medical decision-making capacity? This first bullet point might be surprising because I think a lot of people come to us and assume that someone having schizophrenia or bipolar means they lack medical decision-making capacity. And actually, even in inpatients, so hospitalized patients with active and decompensated psychosis, 70% still retain medical decision-making capacity in one study. So really, it really depends on, really is the word, on how it's influencing their thought process around their medical decisions. When it comes to mania, when we see loss of medical decision-making capacity or MDM capacity, we tend to see that it strongly correlates with loss of insight. That can be into their mental health condition, that can be to the medical condition, and loss of appreciation of the risks and benefits of medical intervention. But even when they're actively manic, they tend to have intact cognitive abilities. So I bring this up because, again, when we're trying to figure out whether a patient has dementia, bipolar, or both, this matters. So generally, they have purely just bipolar 1 disorder and they're manic, they shouldn't actually appear demented, so to speak. And then moving down, lacking medical decision-making capacity tended to be associated with lack of insight again, poor attention, right? That can make things look kind of complicated on a cognitive screener, difficulty in abstract thinking, and also seem to be associated with things like higher doses of antipsychotics, stressful life events, and higher burden of psychiatric symptoms, specifically negative and positive psychotic symptoms. And then there seem to be struggles in areas of understanding and reasoning, and then maybe this seems to be even more age-related. But again, if they lack capacity due to a primary psychotic disorder or mania, it tends to be temporary and responsive to treatment. and there can be ways to restore capacity. And when patients with these disorders are clinically stable in the outpatient setting, they have very similar rates of medical decision-making capacity as healthy controls. And so for my last part of this presentation, a very basic approach to capacity evaluations that hopefully you'll be able to apply to the slides later in this talk or to the case that Heather will present is really how do we approach capacity evaluations in patients with concurrent psychiatric symptoms and disorders. So the first step is the presence, you need to assess for the presence of a psychiatric disorder, right? Do they even have that at all? And then if they have it, is it decompensated? Because again, it may not be decompensated and may be stable. And then if it is decompensated, is it actually contributing to their thought process around medical decisions? So I've had patients who are very psychotic and have delusions, but the delusions do not play a role in why they might be refusing surgery. They're not making delusional statements, they're not having hallucinations, and they can actually talk through the risks and benefits despite being very delusional in other parts of their life. And then you may want to consider getting collateral, reviewing prior, advanced directives made when they were psychiatrically stable to better understand their underlying value system. And then again, I already said this, but the presence of psychiatric illness does not automatically cause one to lack capacity, and that some studies have actually found that things like dementia tend to cause more decisional impairment than schizophrenia and then more than depression. I know there's probably lots of questions for that, but I'm going to hand this over now to Heather.
Awesome. Thank you, Thida. Let me go ahead and share my screen real quick. Okay, please speak up if you cannot see the slides. I'm about to share them in slideshow mode.
They are up, not in slideshow mode yet. Perfect.
Awesome. Okay, so for this next case, I'm going to hit on a lot of the same points that Dr. Thant brought up because I think they're very important. But we're going to bring them up in a context of different psychiatric diagnoses as well as different medical sort of contexts. So for the second case, we have a 39-year-old woman. She has a long-standing history of anorexia nervosa, restricting type. She's admitted for treatment of malnutrition with concern for refeeding syndrome. While she does acknowledge her past diagnosis of anorexia, she firmly believes her current malnutrition is due to primary gastroparesis, despite multiple hospital medicine and GI evaluations saying otherwise. During her hospitalization, she consistently declines tube feeds and TPN despite ongoing weight loss and dangerous electrolyte abnormalities. She is very clear that she is not suicidal and she doesn't want or intend to die. She was ultimately deemed to lack decisional capacity, both to sign out AMA and to decline TPN and tube feeds. Her mother was already determined by the patient, longstanding, to be her MDPOA, and mom elected to proceed with involuntary tube feeds until the patient had basically minimum weight restoration and enough medical stability that she was safe to discharge to an eating disorder facility, at which point she was placed on a mental health hold and transferred for involuntary eating disorder treatment. So before I kind of talk about some of the questions that are raised in this case, which include what is the most appropriate timing for psychiatric holds in patients with acute medical issues secondary to decompensated psychiatric illness? Number two, what is the role of a proxy decision maker, MDPOA or guardian in the treatment of medical symptoms resulting from decompensated psych illness? And three, we're going to sort of address again kind of this idea of capacity to consent versus capacity to refuse. But before I answer those questions, I want to talk a little bit more about the impact of severe anorexia nervosa on medical decision-making capacity. So part of the reason I wanted to include anorexia nervosa as one of our cases is because I think twofold. One, it causes a lot of moral injury and moral distress for treating providers as well as bedside nursing, almost anyone involved in the care. And I think oftentimes patients can present very well in terms of their ability to engage in conversation and sort of cognition on more of a basic level. But I think that, so as a result of this, I actually did a deep dive review into the literature, both for kind of the cognitive deficits that we can find in severe anorexia nervosa cases, as well as capacity evaluations and studies that have been done in the past. So anorexia nervosa is the psychiatric diagnosis with the highest mortality rate. There's a crude mortality rate of about 5% per decade, and about 20% of patients who are diagnosed with anorexia nervosa become chronically and severely ill, meaning they do not go into remission after 3 to 5 years. Despite this severity, many patients are reluctant to engage in treatment. This one study found that about a third of patients who did need inpatient anorexia treatment actually lacked capacity to consent for or against that treatment. Different factors that were associated with this lack of capacity included lower BMI, more previous hospital admissions, more previous eating disorder treatments, worst set shifting, which is really just a measure of rigidity and thinking, as well as a focus on detail over the big picture. Interestingly, what they found in this study and then other studies on cognition is that this lack of capacity and the cognitive deficits can't be explained by malnutrition alone. About 45% of the patients in this specific study who had a BMI under 15 had capacity actually to make these decisions about admission for anorexia nervosa treatment. So there's clearly something more going on with the diagnosis and the syndrome itself. Now, there have been a lot of studies that have evaluated neuropsychiatric testing in anorexia nervosa. Some of the big deficits seen that might impact capacity decision-making include altered reward processing, struggles with delayed gratification, right? So really the emphasis on immediate gratification, deficits in set shifting, which again really is a measure of rigidity, and sensitivity to punishment. They also found in this Alzaker study that there was a negative correlation between appreciation, that part of capacity, right, where the patient really understands and is able to apply it to their situation. So there was a negative correlation between appreciation and both rigidity as well as alexithymia. And just to remind folks here, alexithymia really refers to an inability both to identify, but also to express and describe emotions in oneself. The values, I thought this was also another really interesting study. They basically evaluated values regarding life and death in both acute phases of illness and then later once patients were in remission. And they found that values during those different illness states really differed in terms of life and death. And they brought up this concept of pathological values. So if someone is in the acute phase of illness, particularly for anorexia nervosa, is it possible that some of the value systems and the emphases that they're placing on life and death versus other things like not eating, not gaining weight, could those be illness driven? Would we want to consider these pathological values? And if that's the case, should they be given the same weight as values that we see in recovery, or maybe values that might be considered to be their more long-term expression of their own inherent value system? Another study found that patients generally support compulsory treatment in life-threatening situations during their recovery phase. And many patients, I didn't include this on the slide, but many patients who in the midst of their acute phase of illness who refused treatment later on felt grateful for that treatment. And it did not seem to impair the relationship that they had with their treating providers. Now, one thing I do think is important to bring up in anorexia nervosa treatment and capacity is this concept of futility in severe and enduring anorexia nervosa. Unfortunately, it's beyond the scope of this talk, but I think it's a really important concept. It's an ongoing subject of a lot of conversation and is fairly controversial, but it's something that I think we need to consider as a medical community, specifically from the ethical perspectives. And before I move on, I want to talk a bit more about appreciation, because again, I think this is such an overlooked but important part of the capacity evaluation, right? So for myself, and then also when I'm working with other colleagues who are evaluating capacity, it's pretty straightforward to see if a patient's able to kind of list off, why am I admitted? What is the team telling me is going on? What is the team telling me are the risks and benefits, right? Are they able to demonstrate that? Yes or no? Pretty clear. I think what can be challenging though is the appreciation portion. So again, this is really evaluating whether the patient accepts the situation as it pertains to their specific circumstances, right? So once someone might say, yeah, the team says that my malnutrition is due to my anorexia, but I don't think that's the case. I think it's from my gastroparesis. Or they might say, yeah, the team says that if I leave without treating my blood clots, I can die, but I don't think that's what's going on. If that's the case, they actually show deficits in their appreciation of the situation, right, and how it pertains to them. Appreciation is correlated with insight, flexibility, and often this is where someone's personal value system are reflected and might actually be impacted about what I talked about earlier, some of those pathological values that might be in fact dictated by the underlying severe mental illness. Appreciation can be impaired by distorted thinking, delusional thought content, cognitive deficits, and that rigidity in particular that we talked about for this population. Okay. So getting back to the questions, so what is the role sort of the appropriate use of medical capacity holds versus psychiatric holds in patients with acute medical issues secondary to decompensated mental illness? So long story short, complicated question, complicated answer. Depends on what state you live in. So I'm going to focus on Colorado. So most medicals in Colorado are not able to do the short-term certifications, the involuntary medications that Dr. Thant talked about earlier. But in general, let's say that you were treating someone on hospital medicine. If they are being admitted and held for medical treatment, or they have symptoms secondary to a primary medical or neurological condition, and they're wanting to leave AMA, then that's a medical decision-making capacity evaluation, right? We don't have to worry about M1 holds in those patients, especially because we're not worried a primary psychiatric illness is at play. So this includes your patients who maybe are delirious in the ICU, even patients who have steroid-induced delirium or have brain tumors that are causing psychiatric symptoms. If the underlying etiology is not what we call primary psychiatric, and I know it can be hard to kind of 1-0 black and white these diagnoses, but if it's not something that is considered psychiatric, but instead psychiatric symptoms due to medical illness, you don't have to worry about an M1 hold. You just use medical decision-making capacity to determine whether or not a patient can leave the hospital or whether they have capacity to refuse or engage in other decisions. Now, let's say you have a patient who has a decompensated psychiatric condition, and as a result of it, it's causing really severe medical issues that are requiring them to be in the acute medical side of the hospital, right? So in this example, we have someone with relapsed severe anorexia nervosa who is requiring labs and likely electrolyte repletion for refeeding syndrome. Or another example would be a patient who is so severely decompensated in their schizophrenia that they're not able to take care of their type 1 diabetes and they end up with DKA. And now they're admitted to the hospital for treatment of these medical issues. In these situations, if the capacity question is about whether someone can leave AMA from the hospital because of medical treatments, or if they can refuse certain medical interventions, even if the reason is their psychiatric illness, if we're talking about medical treatment, you want to go the medical decision-making capacity route. So for example, let's say I have my young man who's 30 years old with schizophrenia and type 1 diabetes. He's in the step-down unit, just admitted for DKA, high risk of leaving AMA. I don't have to place him on an M1 hold to keep him in the hospital. What I want to do is complete a decision-making capacity evaluation. And even if he doesn't pass the or even if he's determined not to have capacity due to schizophrenia, like delusions, I can still keep him in there for capacity reasons. I don't have to place the M1 hold. Now, let's say we're in a situation, so our same gentleman who's 30 years old, a few days go by, he's medically stabilized, doing great, but he's still not showing that he can take care of his basic needs due to his decompensated schizophrenia. If that's the situation, now he's ready to go medically. I need to evaluate as a psychiatrist or even the primary medical team. Let's say he wants to leave, psychiatry isn't here today, what do I do? If that's the case and you're worried about his ability to function on his own, that's going to be an M1 hold. Okay, so to differentiate, once all of the medical stuff has been figured out, but you're still worried about a patient's safety, that's going to be an M1 hold if it's due to their underlying psychiatric illness. And then, of course, things get a little more mucky when there's intellectual disability, as well as dementia at play. In those cases, it would be more of the capacity. But for the reasons of this presentation, mental health hold for psychiatric reasons. Okay, so things get a little more complicated in facilities with the appropriate 2765 designations. And when we talk about 2765, we're really just referring to the mental health statute. So that's the actual statute number itself. In those cases, for example, Denver Health has a psychiatric unit that's 2765 designated, and they have determined that a hospital system that the consultation liaison psychiatry team can be an extension of the inpatient unit's treatment team. Their consult team is actually able to start the process for involuntary psychiatric treatment while someone is still getting cleared for medical reasons. So for example, if I have my young man again who has decompensated schizophrenia and type 1 diabetes, as soon as I kind of know, I think this guy is going to need longer term treatment, he's refusing all of his psych meds, I can actually place an application for the short-term certification as well as a court date while he's simultaneously being treated for his diabetes. And just so you guys know, it's something that we are trying to work on, getting our team to have ability to do at UCH, but we are not yet able to do that despite having a psych unit. Okay. So specifically coming back to the eating disorder patient. So if let's say your patient is refusing medical treatment, the first thing you need to do is really determine the urgency of this treatment, right? So let's say that the last, potassium that you got for this patient was 2.1, and now she's refusing labs, refusing any sort of repletion, any sort of PO intake. That might be a little more urgent than, let's say, if we're only worried about orthostatics, but she's accepting IV fluids, but no actual nutrition. Okay, so how urgent is the situation? The next thing we want to do is, let's say she's refusing this, but not that. We want to do a medical decision-making capacity evaluation on the specific decisions at hand, right? So again, we don't want to blanket say this patient cannot make decisions for herself. It's really situation dependent. She might have capacity to be able to say, I only want labs twice a day instead of 4 times a day, or whatever they are, versus being able to leave AMA. If available, in these really, really complicated cases, if at your hospital you have psychiatry colleagues, consult them early because they can help with things like diagnostic evaluation, risk evaluation, where's the motivation coming from when they're making these decisions. And then oftentimes we can join you with the formal capacity evaluation so we can all discuss as a team afterwards, because again, we're not alone in this. So let's say we determine a patient doesn't have capacity for a specific decision. The first thing you want to do is determine the etiology, right? How much of this do we think is delirium? What is there a component of severe depression? Is it malnutrition or the eating disorder itself? And then as we identify the etiologies, we want to work on restoring the capacity as we're able to. And I'm going to talk more about this at the end. And then of course, we want to make sure that we have a decision making sort of medical decision-making proxy. Okay. So what is the role of a proxy decision maker or an MDPOA, a guardian in psychiatric treatment versus medical treatment? Because this comes up a lot in the medical hospital. So decision makers can consent to treatment for primary medical conditions as well as medical symptoms caused by decompensated psychiatric conditions. So for example, let's say that our young man again with the DKA, he's not able to consent to labs. We can call his MDPOA and they can consent for labs. Same thing with the eating disorder patient. Medical decision-making proxies can also consent for things like medical placement. So SNF, LTC. So this might be, your patient who has advanced Alzheimer's dementia, having their medical proxy decision maker consent for placement. Now, what can they not do in Colorado? So they cannot consent for psychiatric treatment. So even if mom says, I want my son to have risperidone, even if he says no. If he's saying no and he's not acute danger to self or others, we cannot give him risperidone, even if his MDPOA says give him risperidone. That actually falls under psychiatric mental health law. Let's say, and then the MD-POA cannot consent to psychiatric placement. So for example, they can't say, I want them at this hospital instead of that hospital. And then lastly, they cannot decline emergency psychiatric care placement. So let's say that psychiatry goes and they determine that a patient is still at acute risk for injury to self and requires inpatient psychiatric placement. An MD-POA cannot sign them out and cannot have them leave against medical advice. So this is all based under mental health statutes. So going back to this case, now let's say that we have our patient, we've seen her, she lacks decisional capacity for tube feeds, for example. We're not just going to go ahead and tie her down, give her a bunch of meds and force her foods at this point. Again, the urgency really, our reaction depends a lot on how emergent the situation is, but we're going to do everything we can to work with the patient and treat them voluntarily. This part I cannot emphasize enough. So let's say though that we tried everything, the patient's still refusing treatment and they continue to decline medically, and we're really kind of more urgently worried about their safety. So the first thing you want to ask yourself, let's say you tried everything, patient's still declining. Are there still medical conditions necessitating inpatient medical treatment, and are they urgent? If so, yes, then that's when you want to meet as an interdisciplinary team. So this is going to be nutrition, medicine, psychiatry, ethics, bedside nursing in this case, as well as the patient's medical proxy, because they're really going to be talking right for the patient's value system to come up with a plan for involuntary treatment. However, let's say you have the patient where you're treating them in the hospital for chronic osteomyelitis, right? And ideally you would get an MRI of their foot. They would be on long-term IV antibiotics, but the risks of them leaving without these aren't super high. If that's the case, then you might want to call psychiatry, who will come. Let's say that it's a patient with decompensated schizophrenia, refusing all the care, but there's nothing really, really significant that's keeping them in the hospital. Then you're not going to treat them against their will. Instead, you'll call psychiatry to come and evaluate the patient to see if they do meet criteria for involuntary treatment. So in this case, let's say you have a patient who is in the hospital, has an eating disorder, but they're not bradycardic, there's no concern for refeeding. We might come and evaluate whether the patient meets criteria for an M1 hold. And just a couple more slides. So I want you to take just a few seconds to think about, in this situation with the patient who we have a lot of concerns about refeeding, she's symptomatically hypotensive, bradycardic, would you allow this patient to consent to tube feeds or TPN? How does your threshold to say that they have capacity to consent compared to the threshold to say that they have capacity to refuse? So again, this really kind of goes back to that concept earlier about how capacity is a sliding scale. So the weight and the risks of the decisions really impact your threshold to say whether or not someone has capacity. Okay, so in this case, let's say that she's basically able to give us some basics. Yes, this is what's going on. I think that I need the treatments. We're going to go ahead and start the tube feeds because we know medically that that's what she needs. But what if she says, I'll accept the tube feeds, but her etiology of the malnutrition is misguided? What if she does think it's the primary gastroparesis? There's no right answer in this case. I think in this one, it's worth a discussion amongst the team about whether you should also bring in her MD-POA and just kind of talk to them about the risks and benefits in the context of anorexia. Just because in this case, it's clear the patient doesn't formally have capacity to consent to tube feeds, even though that's what we want them to do, right? So just because it's what we want the patient to do, it doesn't mean she has the capacity to consent. So in this case, I think it would be worth bringing her MD-POA to help make those decisions. Okay, so real quick, what if the patient has borderline personality disorder? So unfortunately, I didn't find any studies on the rates of incapacity for psychiatric or medical decision-making in this population. But what we do know, it's a very treatable psychiatric disorder. There's very clear psychiatric and neurobiological abnormalities. During a crisis, someone might feel completely affectively overwhelmed and resort to self-harming as a way to regulate distress in the moment. They might also subconsciously punish themselves when overwhelmed, or even providers by refusing recommendations. Oftentimes, patients are not aware of the motivation behind what they're saying or doing. So they're not being manipulative, right? Because manipulative implies really intentionality. That's not the case in someone who's in the midst of a crisis who has borderline personality disorder. Oftentimes, folks are completely overwhelmed that they're just not thinking clearly and they're not doing things intentionally to be a problem patient. It's coming from the disorder itself, and it's very distressing. Different symptoms that might influence the way information is interpreted to impair decision-making capacity in this diagnosis include splitting, black and white thinking, over and under evaluations of team members, and even paranoia during times of crises, right? That's where the term borderline paranoia or borderline personality comes from. It's sort of borderlines in times of crisis on the psychotic end of presentation. Symptoms of this diagnosis likely are impacting appreciation and reasoning when it comes to capacity evaluations, and cognitive tests are usually normal in folks with borderline personality disorder. Now, what about severe depression? Let's say you have a patient who's severely depressed. Here you can see deficits in executive functioning, working memory, new learning performance. About 24% of depressed patients lacked decisional capacity for psych treatment in that early study by Grosso and Applebaum. But again, keep in mind, this is inpatients, so patients that are severe enough to require psychiatric inpatient treatment. Sometimes in depression, you can see diminished concern for one's own well-being, an inappropriate valuation of risk, and underestimation of potential benefits of treatments. Neuropsych testing shows different types of cognitive disability, so inability to appreciate, and then this can impact sort of understanding and reasoning. And this other study found that in cognitively impaired depressed patients, they understood information less than the control group. Interestingly, depressed patients who are not cognitively impaired understood information about the same as the control group. So it's clearly some of these cognitive deficits that are really impacting thinking here. The other thing, like all these other diagnoses, you really want to ask yourself, are the values that they are expressing that's driving their decision, is that driven by their severe depression? Or is it consistent with their underlying value system that's more chronic and consistent? So how to approach impairments in decisional capacity? So it's the duty of the treating provider, us, right, for most of us, to determine both the etiology and capacity and to enhance capacity where able. When you are trying to restore someone's capacity, you want to use the least invasive and safest capacity supporting interventions available. The therapeutic relationship that you have with the patient is key. So this is where you bring in trusted family, friends, clinicians, maybe outpatient clinicians to better understand the patient, but also to get them to start having conversations with the patient. You might want to consider additional cognitive testing to really understand where these deficits are coming from. And of course, make sure that you are frequently performing reevaluations when clinical scenarios change, right? So let's say we determine delirium or maybe a decompensated psychosis are the etiology of the lack of capacity. Those are two things that can progress and change with time and treatment. So we have to reevaluate capacity as appropriate clinically. A couple of interventions to support capacity restoration. So these include enhanced informed consent. Most evidence is in schizophrenia. This is something that all of us can do in clinic. All of us can do this in the hospital. More formally, when you look at the studies of this process, they'll use interactive consent procedures. So like a video, as well as maybe some pictures and repeated presentations over the course of like 30 minutes over a few days. But really what all this means is if you have a patient that maybe has one of these disorders that's impacting their capacity, repeat information, simplify the information, have them teach it back to you. That is evidence-based to help enhance and restore capacity in many, many cases that are statistically significant. Now, metacognitive retraining, that has evidence mostly in schizophrenia, but a couple of other disorders. That's really just thinking about thinking. So that's kind of what we talk about reality testing. So playfully kind of asking a patient when they say, well, I can't do this because of that. And you're like, I wonder, is that really true? what about this case? That has evidence base to improve capacity. Recognizing and cueing, improving during information discussion. So really what we're talking about here is when you're talking to a patient about the situation, don't just talk at them for 20 minutes, right? If someone is severely depressed, they have deficits in attention and short-term recall. What you want to do is maybe after you finish a certain bullet point in the conversation, have them teach it back to you. Talk about it as a conversation. Don't just speak at them. And then enhancing emotional regulation can be really, really helpful in anorexia nervosa and borderline personality disorder. And then, of course, tons of evidence in the psychiatric world for shared and supported decision-making. So this is where we bring in, when someone is well and at their baseline, psychiatric and medical advance directives, as well as involving those trusted outpatient partners, family, friends. And we know that this leads to more adherence in psychiatric and probably medical treatment, though the data is not quite there yet. So that's it for the formal presentation. We'll have a few minutes for questions, so we can go ahead and get started with that.
Great, thank you both so much. That was incredibly informative. We've had quite the chat, so I'll pull a few of the questions. As a nurse care manager, how can I advocate for a capacity evaluation sooner? My experience with my patients is that they most often do capacity evals at the time the patient is wanting to leave AMA and has escalated. I work very complex patients who are unhoused and often have the additional difficulties that come with mental health disorders.
Yeah, so I can start, and then Heather, you can always jump in, because I mentioned it in my part that it is challenging because you can't always like proactively or preemptively do this. So AMA discharge is obviously like kind of a classic time that this gets raised, but because it really depends on like, what is the clinical status? Has it changed? You know, what is the decision being made at the time? Are they actually declining things, right? So if someone comes in and their status is, you know, more stable and they're kind of accepting things, they may have capacity at that point to kind of consent or refuse. But then, and even if you decide and evaluate them and say they have capacity or that they don't, when a new clinical scenario comes up a week later, they've gotten more delirious or they've gotten more sick, the kind of math has changed. And so capacities get reassessed. So that's why oftentimes we're having to reassess at that time. And I think our tips are often like trying to kind of de-escalate the patient. And then you may try the capacity eval. If they can't really engage with you at that point, you know, kind of letting things calm down, trying to kind of see how we can get, you know, everyone in a better place, and then revisiting the conversation a bit later. And so sometimes you can't get it all done in that moment when they're like yelling and trying to walk out. But I don't know, Heather, anything else you have to say about that?
Yeah, I agree. I think actually it also brings up almost this other point and question of, you know, when should providers in particular think about and get involved with and have interventions for agitation sooner, right? So we know that at least at UCH, our nursing colleagues have flow sheets. They do a BROSET score every single shift. But how does that translate to providers and what are we doing about it? So I think part of the getting ahead of it also includes us talking to our nursing colleagues and identifying at-risk patients and sort of figuring out, okay, what has led them to leave AMA in the past? What are current risk factors for AMA discharge? And what can we do now about it, right? Is there some component of withdrawal, for example, that we can treat? Or maybe we can cluster cares to not interrupt their sleep at night, right? So these things that maybe we can get ahead of it, that's less of a capacity question, but more an investigation of what's led to that AMA or AMA risk factors we can address.
Great, thank you. Are there any special considerations that have arisen within the rise of medical myths or disinformation? Does holding a belief that COVID isn't real, for example, count as delusional thinking?
Ooh, this is definitely a question that this is the whole talk of in and of itself, right? I think it does bring up, though, a good question about, you know, things that are considered sort of culturally norms or like relevant within certain cultures, right? And so I think about that when I was on inpatient psych as a resident, and we would admit someone who was originally from Somalia, who had some beliefs that were considered psychotic maybe by us, the admitting team, but we would reach out to like the minister in her church and other people within sort of her culture and her group to ask about whether those belief systems seemed a little beyond what they would consider to be appropriate and normal. I think with COVID misinformation in particular, it's a very, very challenging situation. I think that if it's a conspiracy theory that unfortunately has gained popularity. It's considered a cultural norm, and I don't know, I wouldn't consider that psychotic myself. But that's a tough question, and I don't have a good answer for you. Thida, what are your thoughts?
No, I was having the same thoughts. I mean, I think we'd want to see like, how does that tie in to prior beliefs and advanced directives? Is that a huge shift? Do they have other symptoms concerning for like a delusional, like a true DSM-5 delusional disorder, psychotic disorder? So we'd be trying to see, are there other things in relation to that? Are they having other symptoms? But those never feel good for anybody.
No. I had a patient who didn't receive a heart transplant because he refused to get the COVID vaccine, and he died in the hospital. So, and it doesn't feel good. I wish we had better solutions.
Yeah, gosh. Good answers though. You guys talked a little bit about how some consult liaison teams get to act as extension of inpatient psych teams. And what are the current roadblocks to having, you said you were working on it with UC Health, but what are the current roadblocks?
It's sort of, it's just kind of stuck in like legal review right now. It's sort of a short answer. So that kind of logistics, I think the system wants it to happen. There's just a lot of steps of trying to make that happen. It's been such a long time since we had that designation here. So I think the last I heard is it was kind of in review at that level of the system, the paperwork and the wording and all of that.
Great. Dr. Thant, you talked about this a little in the chat, but I figured you could expand on it here. Where do temporary mental problems fit into this? Examples: ICU or post-ICU critical care psychosis or delirium, PTSD, medication-induced psychosis or delirium.
Yeah, I gave a brief answer to the thing, but yes, the easiest distinction is that most of the things in that question are considered medical disorders and not psychiatric, which I know sometimes is a bit of an arbitrary distinction, but those get lumped in. Delirium is considered like a medical condition, all these things. So that can fall under kind of the proxy medical decision maker MDPOA process. PTSD is one that would technically fall under the mental health process. And so that's why there's a distinction. So if someone has like schizophrenia, for example, but they are actively delirious and septic in the ICU, and they're agitated from that and confused, we could use Haldol, for example, to maintain safety. But once they're kind of cleared from that medical emergency and they're not delirious, and we believe that their symptoms are coming from their schizophrenia, then we kind of have to shift course with the policies that we follow, the statutes that we're kind of reporting to.
Great, thank you. Like I said, really excellent talk. This will be available on CU's Bioethics and Humanities Center website and sent out to you after the talk. As a reminder, our next Ethics Grand Rounds will be on April 11th at 11 with Dr. Channing Tate discussing disparities in hospice care. Thank you both so much, and I hope everyone has a great snow day.